So hello, everyone. Thank you for joining us today for another exciting webinar. This session is part of an educational series put together by the World Federation of Neurosurgical Societies, especially the Young Neurosurgeons Forum. And these can be viewed online on our YouTube channel at your convenience afterwards, along with the series of 15 to 20 videos we've already done. And today we have an opportunity to speak with Dr. Timothy Smith. He has an MD, a PhD, and an MPH, and he's an assistant professor of neurosurgery at Brigham and Women's Hospital, one of the Harvard teaching hospitals. He's also the director of the Computational Neurosciences Outcome Center, known as CNOC, which is a research lab with its core in the analysis of data related to care, management, and outcomes of neurosurgical patient populations. So thank you, Dr. Smith, for joining us today.
Great to be with you. Faith, thank you so much for the invitation.
And just to begin, can you tell us a little bit more about your interest in statistics and patient outcomes in general?
Yeah, sure. So as you mentioned, my background is MD, PhD, MPH. So my PhD is in epidemiology, master's is in quantitative methods. So I have a tremendous interest in population health, statistics, epidemiology. And when I first sort of went through my training, which was now a couple of years ago, there was a lot of question amongst those interviewing me whether or not I would be able to apply my background to neurosurgery. And one thing that has become abundantly clear now is that data science is essentially moving to the forefront in terms of research and clinical care. So it has worked out tremendously well for me. So my lab, which we refer to as CNOC, is a lab that is dedicated to using data science to improve patient outcomes. And my lab is sort of broken up into classical epidemiology and biostatistics for modeling. And then we also have artificial intelligence and machine learning algorithms. And we use both of these to answer what we feel are very important questions.
It's a very productive lab, from what I understand. You yourself have over how many hundred publications now?
Yeah, we have a great group, actually. So our lab is composed of a number of international fellows these people are mainly MD, PhDs who come to us for a year or two and devote a lot of their time towards answering important questions. And then we also work with a lot of medical students from the Harvard family as well as others. As you know, these folks tend to be incredibly skilled, highly motivated. So yeah, our lab, I would say, is probably one of the most productive in the country.
That's very impressive. And from that, can you tell us a little bit more about, I don't want to go too far into your talk about what is digital phenotyping, but how did you get an interest in that originally?
Well, this actually occurred to me when I was a fellow. And when I was a fellow, I was working on an endoscopic skull pituitary fellowship with Dr. Ed Laws here at Brigham. This was about 6 years ago. And one of the things that we noticed with our patients is that pituitary patients specifically had just a spectrum of symptoms that was beyond our capacity to quantify. So we would be sitting in the clinic with a patient and they would be telling us just a laundry list of all of their complaints, which were real, but incredibly challenging for our current system to identify, quantify, codify. So patients would say, I have issues with memory. I feel like I'm emotionally volatile. I don't think I'm quite myself. I feel like I'm in a fog. I'm in a haze. And these are things that historically patient-reported outcome measures, which is essentially the gold standard for tracking patient quality of life, were woefully inadequate for tracking. And at the time, I was carrying 2 smartphones. One was directly related to all the clinical care related to my fellowship, and the other was my personal phone that I used at home. And I had those phones with me 24/7. And it occurred to me that I was putting myself through a host of neurocognitive assessments every time I interacted with my phone. And simultaneously, one of my colleagues, who's one of the deans at the Harvard School of Public Health, reached out to me because she knew the work that I was doing. She said, you have to connect with Dr. J.P. O'Nella. He is working on similar things. So we met and we started talking, and we realized he had already done a tremendous amount of work in social networks through smartphones, and he had developed a platform for starting to collect data. And we realized that there was going to be an amazing collaboration for developing a lot of clinical utility from what he'd already done. And that's when sort of our Brigham digital phenotyping was born.
Very cool. Well, we're all very excited to hear more about this in detail, about how you've been using it already within neurosurgery, and then applications outside of neurosurgery, and then kind of how you maybe foresee. I think a lot of things now in this COVID pandemic have, the pandemic itself has been a catalyst a lot for digital health and doing things remotely, remote monitoring. And when we talk about going back to normal, I think we all know that the new normal is not going to be what it was 6 months ago. And I think one of the key changes in healthcare will be the advent of accelerating a lot of the use of digital technology for improving the care for our patients. So
yeah, absolutely.
With
all
that,
right,
go ahead and share your screen.
All right, can everyone see this okay?
Yes, we see it.
Great. So I'm going to spend a little bit of time in this presentation starting with the background of digital phenotyping, but then I'm going to apply it to COVID-19 in terms of one of the projects we're working on here in our partners family of hospitals. I currently have no conflicts, constantly looking for a conflict. Maybe I'll have one next year. All right, so in terms of a lot of people ask us, why do we use a smartphone for this when there are other devices that may be more accurate at, let's say, at counting steps or at heart rate or EKG? And the reason that we have selected a smartphone is because since its introduction in the form of the iPhone in 2007 to 2020, now in terms of world adoption, 90% of the world's population over the age of 6 owns and operates a smartphone. So in terms of scalability, there is no other piece of technology in the history of humanity that has been adopted so rapidly and so pervasively. So this is a piece of technology that if I would have told you 20 years ago, prior to the smartphone, if I would have told you 20 years ago, hey, I have an idea, I want to give everyone a digital device that they carry in their pocket, and then I'll track people using this device, people would have looked at me like I was insane. They would have said, well, why would people carry this? Who's going to pay for this? Why in the world would anybody want to travel with this device? Because we wouldn't be able to anticipate how ubiquitous the smartphone was. Now, today, everyone that's on this call, I guarantee you, would never leave home without their smartphone on them. In fact, I would wager that many of you are using them right now as I'm giving this talk. In fact, the average American touches their smartphone screen over 2,600 times a day. So, and I would argue that actually for the people on this call, that's probably more. You probably do this more than the average. What we believe is that we can develop what we call a digital phenotype from your interaction with your phone. So every interaction that you have with your phone leaves a data shadow, a data trace. We believe we can bring these data streams together and we can create a phenotype for behavior the way that you interact with your phone. The specific definition is moment by moment quantification of individual level human phenotype in situ using data from personal digital devices and in particular smartphones. So the phone gives us an amazing opportunity to capture social, behavioral, and cognitive phenotypes what we call in the wild or in an ecological setting, real world data. And we know that according to the National Academy of Sciences, that 80% of all healthcare diagnoses are social, behavioral, and cognitive. So having a device in your pocket or in a patient's pocket that we can marshal to actually help establish these diagnoses, I think is incredibly powerful. We use a collection of raw sensor data to allow reproducible research and pooling for reanalysis and for the purposes of reproducibility. We use a lot of data streams from these devices. We use active data and passive data, and we'll get into a little bit of what that means. Active data includes things like a person taking a digital survey on their phone, series of questions that they answer, or giving us a voice recording. We also do capture. We're developing cognitive tests, but we use passive data streams as well, like accelerometer data, gyroscope data, GPS, Bluetooth, near field technology, text logs, call logs, phone and screen state on off, charge state, Wi-Fi triangulation data, as well as others. And it's through data streams that we develop phenotypes. Now, this slide shows data summaries. So we can take this raw data and we can start developing mobility features, sociability features, the results of survey, activity features, sleep features, power state, data coverage. And all of these are features that we summarize from raw data, from massive amounts of raw data. And you'll notice that, for instance, under mobility, we can calculate time spent at home versus time spent in a car, time spent commuting, time spent at the hospital. All of this comes from passively acquired data from the phone. In terms of the background of how we actually do this from a technical perspective, there's a front-end application that's a skin on this that runs on both Android and iOS phones for collecting all the data. This is back-ended in the cloud. So we use Amazon Web Services for this as our cloud computing infrastructure. This is eminently scalable because we collect about 1 gigabyte of raw data per subject every month, which this represents about 1 billion points of data per patient. We have a study portal for managing all the different patient studies that we have and for downloading the raw data. We've developed a dashboard for monitoring study progress and basic data metrics. We also have a cloud-based data analysis pipeline because the computational side of this work is intense and very heavy. We have data collections, a system that's based on EC2 instances and Elastic Beanstalk. And of course, we have medium and long-term data storage solutions as well using Amazon. And this is all HIPAA compliant. In terms of the platform, there's a lot of words on this, but I will highlight the salient features from this slide. Number one is that this platform, which is called be.we. be.we is a Nordic goddess of sunlight and health. And Dr. Onnela selected this because he is from Finland. And a lot of the culture in Finland revolves around the sun because they are very north. And so there are days that are very long and days that are very short. And so be.we had a prominent place in that culture. So there are several guiding principles. First off, we wanted to ensure that when this was developed, there was an incredibly high quality code base that would be reproducible and open source. This was programmed for both Android and iOS to allow accessibility for essentially all smartphone users. There's still apparently, some fraction of a % of people out there that are using BlackBerry, but for the most part, everyone's using Android or iOS. We wanted to make sure that we collected raw data. There's a lot of services, a lot of platforms out there that don't deliver raw data. They delivered summarized data or processed data, and then it becomes very unclear the assumptions and decisions made along the way to condense the data. we thought this was going to be very important for pooling and reanalysis of data at a later stage. We wanted to make sure that it was HIPAA compliant because it had to be completely private and useful in the healthcare setting. And we wanted to make sure that there was configurability associated with the platform to accommodate data collection across various studies. We have one-click replication of the data using JSON config files, which is essentially just using a JavaScript instead of XML. And we have scalable cloud-based data analysis pipeline. So this is very helpful in terms of collecting, storing, and analyzing the data. All of this is based essentially on web services. So if you look at essentially what I would call 36 other software systems worldwide that claim to do something similar to this, be.we platform, at least until this month, is the only platform that actually accomplishes all of these bullet points. So once we collect the data, we summarize the data into features, then we can start using first pass data summary statistics for inference, which we refer to as our primary insights. And this is both using supervised learning as well as unsupervised learning. Both of these are forms of machine learning. And this is an example of one that we'll come back to later. Once we've developed sort of the primary insights, we can come back and then actually develop deeper learning insights, which are going to be methods-based and require the development of novel statistical maneuvers to inform the entire analysis. So, for instance, I'm going to go through a couple of examples of these, but this has been used to develop predictability indices. For example, when will a patient be readmitted after surgery? Will they relapse from having a schizophrenic break? Will they develop major depression, and when? What's their cognitive status? Are they currently in pain? Mobility statistics, sociability, isolation, loneliness, predicting stroke, heart attack, postoperative complications, multiple classifications of activity, and more. So I'm going to give you some examples of these after I go through the first question. That's probably the first question that's posed to me when I talk about this topic is privacy related to using smartphone data. So this was a driving core principle of the design, was to make sure that we were HIPAA compliant, and in terms of the ethics of data science, that we were making sure to protect patients at all times. So, and I'm going to go through this in a little bit of detail because I think it will prophylactically answer a lot of good questions of those that are listening right now. So the platform assigns randomly a user ID. In other words, we're not using the patient's cell phone number as an identifier, which is the case in many apps. This ID is the only identifier that links the person to his or her data. The data is buffered in an encrypted form on the device. The platform then attempts to upload the data, which it does normally hourly, but only in the context of Wi-Fi availability so that we don't drain the person's battery. And then once the data is uploaded, it's deleted from the device. So all data on the phones and on the server and in transit are using industry standard double encryption techniques. So here are the techniques that we are using. So not only are we removing the identifiers from the collected data, but we're encrypting all the data while it's stored on the phone, and we're encrypting all the data on the server once it arrives. And this is in the form of anonymizing the identifying data and hashing the phone numbers. Every phone generates a unique cryptogenic code, it's called SALT. And during registration process, and then we use that SALT to encrypt phone numbers and the MAC addresses for the device themselves. The SALT never gets uploaded to the server and is only known to the phone for this purpose. Then, using secure hash algorithms, SH256, and password-based key derivation functions, these identifiers are transformed into an 88-digit anonymized string that can then be used for data analysis. And then the de-identification cannot be undone because nobody knows the SALT. It is not retrievable from the phone. The data then are re-encrypted for storage on the server, and during registration, without any user involvement, the platform provides the smartphone app with a public half of a 2048-bit RSA, which is a Rebus-Shamir-Adelman encryption key. With this key, the device can then encrypt the data, but only the server, which has a private key, can decrypt it. Thus, the app that we've created cannot read its own data that it stores only temporarily. Then this RSA key is used to encrypt symmetric yes keys for bulk encryption, and these keys are generated as needed by the app and must be decrypted by the server before data recovery. Data received by the re-encrypted with the master key and then stored on Amazon S3, the industry standard for secure storage. So in addition to these things, investigators themselves cannot access certain designated data streams, but can compute on them. GPS data is considered directly identifying, and this is an issue that we've had to face, certainly by an increased number of IRBs, because GPS data is accurate within feet of where the person is. Therefore, the platform adds randomly generated noise to the latitude and longitude numbers, but not to the timestamp, and this noise cannot be subtracted. So what happens if someone finds out a subject's password? If there are pending surveys or audio recordings, these can be completed, but they cannot view any past data because the phone itself has already deleted it. What happens if someone gains possession of a person's device or a phone? If they manage to gain physical access to the device memory, they might be able to gain access to about 1 hour of encrypted data at most. And this encryption cannot be broken. Okay, so with that as a background, what kind of projects have we done in the past? Well, this is a bipolar study looking at patients that have a bipolar break in the form of depression. And this was used with a Markov model. We're going to come back to these in just a bit, but this is just a broad overview. This is looking at a simple decision tree of whether or not people in these sort of common workflow areas, are they within their home? Are they in transit? Are they at work? And this is a part of our larger, what we call a lifetime quantifier, where we can divide up our lives into the amount of time we spend doing various activities that sort of in sum equal the quality of our lives. This is looking at predicting suicidality in patients using a daily survey on the phone, which is the PHQ-9 score, and then looking at over time, and this is for one patient from 0 to 30 days, looking at suicidal ideation over time as related to their self-reported PH9 score. And the prediction accuracy of that simple data stream is approximately 70%. We can also look at mobility, which I think is really important, especially in our surgical patients. And we can then start linking that to clinical events like presentation to the emergency room. So here we have a graph that shows us steps and time away from home over time from day 1 to day 43. Here in colored lines, we have chemotherapy being administered in red, an urgent care visit is in yellow, an emergency room visit is in green, hospitalization would be in blue. And what we've been able to determine is that simply by using step count, we can start to predict when a patient is headed either to urgent care or to the emergency room. And I think that's an incredibly powerful thing because it doesn't rely on the patient reporting how they're feeling. We can just track their mobility and start to anticipate adverse events. This is an example of how the data is visualized. Here's a voice tracing right here, a voice data sample. And this is a Wi-Fi signal data sample. Wi-Fi is an interesting data stream because at any one time, your device has access, at least if you're in an urban setting, has access to hundreds of Wi-Fi signals. Now, only 10 to 20 of those are actually visible to you at any one time on your phone, but we can create incredibly complex Wi-Fi signatures that represent location without even needing to access GPS data. In patients or people that are not in urban settings, then we use GPS data. And this here is an example of one of our postdocs on their bike, riding down Longwood Avenue, parking their bike, coming into the lab. And this is incredibly accurate, the most accurate location data that is available on phones. This also gives an example of outgoing, incoming call and text logs that we use to build very complex social networks from. This is a Bluetooth data sample, which is a near field technology. And this is how we can use phones to detect other phones in a near vicinity. This is accelerometer data, which is helpful for step counting. And now we can take these data streams and we can start to anticipate and to build models for things like activity. So here on this graph, you'll see at the top, there's a bar graph of what we considered the truth about activity. In other words, this is a monitored person wearing a smartphone who we are watching take steps, walk, go up and down stairs, and standing. This is the truth. Using just the accelerometer and gyroscope data off their phone, this is the prediction based upon smartphone alone. And you can see that it's not entirely absolutely perfect, but it is an amazing approximation for not having the person wear another digital device. This is a graph getting at something different than activity. This is mobility. So it's not, what activity are you engaged in terms of walking, standing, sitting, laying down, but how far are you moving through the world, through time and space. So this here to the left shows a tempospatial map that has both a spatial dimension, and you'll see here for this, what we call a pain-free day. This is a patient that is spending most of their time at home, and they are commuting to work on a bus, and they're staying at work most of the day. The color coding is day and night, and the size of the sphere is the amount of time that they spent in that particular location for the day. And you'll notice this is a pain-free day. This is a significant pain day, where the patient spends most of the day at home, and then maybe has one walk outside, going to the store, walking the dog or whatever, and then they're coming back in. We can also develop incredibly complex sociability metrics based on digital social networking data. And this to the right here is based on 100% call log, which is incoming, outgoing data, and we can build complex social networking, how people are motivated and changed by their communication patterns. We can also look at sleep, and I think this is revolutionary. So over here to the left, we have a graph that shows the data from 100 undergraduate students wearing a research grade somnograph, which is basically a wristwatch that you wear that tells you when you're actually sleeping at night. We thought to ourselves, can we reproduce this using just smartphone data, screen on off state combined with interactivity with the screen? You'll notice that the blue dots here are screen on, and we superimposed these and discovered that there was about a 95% predictability of just using screen interactivity for undergraduate students. So we don't need them to wear a sleep device. We can just check their phones and have a sense of when they're sleeping. We can also understand language very well, both written language and spoken language. And we can start superimposing language function using text data, call data, accuracy data, and voice recordings to get a real sense of whether someone's developing an aphasia, either expressive or receptive. And again, we're not just checking the content of the text, but we're also looking at metadata. So how many texts are incoming? How many are outgoing? What is your texting response time? Has it gotten longer? Has it gotten shorter? And when you formulate a text, what is the lexicon that you're drawing from? What is the grammar? How many errors are you making before you send it? How much time does it take for you to craft the text? All of these data we're collecting and using them to analyze language function. One of the things that we're exploring this year, which I'm very excited about, is this idea of mood or affect from a digital signature. So over here, this is a very interesting study out of the UK. This is not one of ours, but it demonstrates a point, and that is from a photo, you can elicit a tremendous amount about the affective content or the mood of the individual at that moment in time. This was a study in the UK that looked at the impact of alcohol on a person's affective content in their image. And this is a person who had started the study with no alcohol. This is a picture after 1 drink, a picture after 2 drinks, and a picture after 3 drinks. And you'll notice over time that as this person becomes more disinhibited, the emotional content of their picture changes dramatically. And with the amount of selfies that people are taking today using their smartphone, we think this is one way to get a picture into the mood of the individual for the day. Another way to get at it is the use of emoticons or textisms through text. One of the challenges of texting people, as most of you know, is that it is a challenge to try to communicate emotional tone. So the way that most of us do this is we either use an emoticon that represents how we feel, or we change the way in which we type to add emphasis. So we're either using a lot of exclamation points, question marks, or changing the spellings of words to make them longer or shorter to add emphasis. And we believe that we can use these to start to drill down on how a person is feeling that day based upon how many of these and how they're being used. And then, of course, we're developing cognitive proxies. So if you think about the neurocognitive domains, which there are 6 accepted neurocognitive domains, your smartphone is putting you through neurocognitive testing essentially every time you use it. So perceptual motor function, complex attention, social cognition, executive function, language function, learning and memory, all of this is being tested when you're using your smartphone. So that brings us to the particular application for COVID-19. Can we use digital phenotyping to in any way help with COVID-19? So the mantra from an epidemiologic perspective is until we have a vaccine or effective treatment for this, we're going to have to test, we're going to have to trace, and we're going to have to isolate. So that means testing in the form of who has the disease or who has had the disease. And we need to contact trace the people that are C19 positive, and we need to isolate those that are asymptomatic but infected. So this is a general epidemiologic principle that historically has been done through brute force using manpower. If you look at the numbers now, so I'll start globally here, and this is as of 4:45 a.m. this morning. There's over 3.6 million cases worldwide and 256,000 plus deaths worldwide. And you'll notice that the 7-day average is essentially plateaued. So we're looking at around 70,000 new cases per day worldwide. If you look at the US, this was updated as of this morning. There's over 1.2 million cases in the US and over 71,000 deaths. Many of these centered around incredibly dense urban areas like New York, New Jersey, Boston, Chicago, LA, and then some hot spots in Michigan and Florida and in Louisiana. If you look at by state, this is where we fall to Massachusetts. These are cases per 100,000 people and deaths per capita. And this over here represents the growth rate. So now here, as of this morning in Massachusetts, we've had 4,200 deaths and 70,000 cases. One of the points that I emphasize when I discuss this is people are saying, at least in the media, how is this different than a normal flu? So far we've lost essentially 70,000 people to this over the last 2.5 months. How is this different than a terrible flu year? An average flu year, we lose approximately in the US around 30,000, 35,000 people to influenza. So this is, people say this is about twice as bad as a flu. And that is a gross misrepresentation of C19. So we lose, number one, 35,000 people to the flu every year. That's with vaccination. So that's an important distinction. That also represents the amortized annual death rate for the flu. This is a death rate that has occurred over 6 to 8 weeks. So the first known case in the US was February 6th. So it's essentially been 3 months, and almost 72,000 people have died. If you look at time-based mortality rates, the weekly mortality rate in the month of April to COVID-19 is exponentially higher than any other cause of death, including cardiovascular disease. And in many states, it is higher than the combined death rate for all of the top 10 causes of death. So this is definitely not the flu. It's something that's, overwhelmed a lot of areas, and certainly places like New York. And this is how we have plateaued. We have taken drastic measures in the US and around the world to try to push what people call the curve down so that our healthcare systems are not overwhelmed. This is just showing you a little epidemiology about what we call the R value. There's an R naught value, which means how quickly does this virus reproduce? How many people will it infect? If it's less than 2, it's considered to be on the mild form. If it's 2 to 4, it's moderate. And it's greater than 4, it's incredibly infectious. And then, of course, combined with that, we have to look at the case fatality ratio. It could be very effective, but it doesn't kill a lot of people. So the worst are incredibly infectious and also high mortality. And we consider high mortality to be higher than 10 to 15%. And what you can imagine, that there were viral components that make a virus incredibly fatal or incredibly facile at transmitting itself. But there's also clearly population and cultural components which change where this falls on the map. So this right here is where COVID-19 falls. So this was SARS and MERS. And if you remember, how many people did SARS infect worldwide? About 8,000. So we're now at millions of infected COVID-19. It's an incredibly effective at transmission. That's one thing that makes it pretty impressive. The influenza, this is 1918, which some people refer to as the Spanish flu. This is something that gets a lot of press, certainly in the media, because this had an incredibly high mortality rate. Of course, that was in 3 waves back in the early 1900s, prior to a lot of population health initiatives. So if we think about our healthcare workers in the hospitals, it becomes problematic because a lot of people can stay home, and those people are staying home. Essential workers cannot, and healthcare workers are considered very essential. So these folks are coming into the hospital and braving exposure repeatedly every day, and we also believe there's a dose relationship to the likelihood of infection and negative outcome. So we have hundreds of people that are COVID positive working at what we call MGB, which is Mass General Brigham. And now they are the highest risk category in the country for becoming unwitting vectors, and we don't really have real-time tracking systems for them. So what we proposed to our hospital system was a fully functional, existing, already built, open source be.we smartphone monitoring platform to collect GPS location and mobility data, combine this with daily hospital administered survey data and the C19 testing data from the hospitals to employees and patients to create a smartphone-based C19 surveillance system. And this essentially involves 2 steps. First is the data collection, which is massive. So our goal was to enroll all employees and patients into the program, which is a very aggressive goal. Have them put the app on their phone and follow them for 12 months or until the vaccine and treatment was available. Next, to analyze this data. This comes from essentially 3 different sources. So one is all the existing data, which comes from the labs, the blood tests, and so forth. The screening data, which comes from employees taking what's called a day pass, where every day I have to go to work, I have to answer 8 questions about symptoms, and I'm cleared for work or not based upon those. And then, of course, passively acquired smartphone data that is both location data and proximity data and physical mobility data and phone usage data, all obtained through be.we. And this will help us discriminate 5 important C19 groups. There's the infected, known infected. There's the presumed infected. So these are people with signs and symptoms that are consistent with infection, but that have initially tested negative. There's the exposed group. There's the unexposed group, and then what we presume to be the immune group, although the jury is still out on what immunity will actually look like in this disease. So our goal was to become the first hospital in the US to deploy a digital remote smartphone monitoring C19 surveillance system using mostly passively acquired GPS data, and then hopefully lead the way in employee safety and so forth. We hope eventually that this will replace and augment the current gold standard, which is epidemiologic contact tracing. And what's interesting is when you look at COVID-19, transmission patterns suggest that epidemiologic control with human being contact tracing, so non-digital contact tracing, would be too slow to actually keep up with transmission rates. So we need to develop a digital version of contact tracing to actually maintain pace with the virus. In terms of what other countries have done so far, China required citizens to download software onto their phone that broadcasted their location to authorities, which included the police. South Korea government used cell phone location data, closed circuit TV, credit card records, so forth, to broadly monitor social distancing. Singapore used an app called Trace Together, which is a digital contact tracing app. The issue with this app, in my mind, is that it uses the cell phone number of the individual as the ID. Germany used an improved version of this, which hashed the ID. And then in the US now, you've already heard that Apple and Google, among others, have started to launch their own initiatives for contact tracing using near-field technology. Now, this is the reason that I think that the Apple Google contact tracing plan won't stop COVID on its own. Number one, these what I view are the issues. Number one is that GPS tracks your location and it tracks it very, very well. Bluetooth exchanges signals with every device around it that has a Bluetooth signal. So there's a lot of social networking apps that are already using Bluetooth near-field technology to determine where your friends are. So if you're going out to eat and you says, hey, Mike is eating dinner at a Chinese restaurant 1,000 feet away from you, do you want to contact him? This is a combination of GPS and Bluetooth working together. Then for the COVID-19 positive folks, health officials obtain cell phone activity and cross-references with all the surrounding phones to get a sense of who you are most likely to have come into contact with. GPS overlaps, so showing that I went to McDonald's and you went to McDonald's, or Bluetooth hits, then they can contact the patients this way and urge isolation or testing. These are the concerns that a lot of us have regarding this kind of a system. Number one is privacy. So HIPAA compliance in the private sector has long been an issue related to social media. Going back to Facebook, Twitter, the use of data in large data science companies has always been an issue. So who should house the data? Who should own the data? Who should have access to the data? These are very important questions. In conjunction with this, currently the testing capacity in the US is very low. So right now we're testing, this is as of last 2 weeks ago, we're testing less than 1% of Americans. So the effectiveness of contact tracing really relies on identifying people who appear healthy but are carrying the virus. So if these people aren't tested, their contacts won't be recorded. That's an issue for C19. We also, in terms of the Apple, Google, right, this API has to be integrated into public health use. There's also the issue of false positive rates. So if my phone senses that you're close by, let's say less than 10 feet away, but you're standing on the other side of a wall, for instance, it doesn't necessarily mean that I've had contact with you. And then of course there's the adoption of this. So I think it's the marriage, it's the marriage of medicine, public health, that is the solution. Certainly here in Massachusetts, our governor thinks that we have already hired an army of contact tracers. So from my perspective, layering the active survey data, testing data with passive location and mobility data will allow us to develop a meaningful strategy for all of our hospitals, both for at the institutional level, how to load shares and resource allocate, forecasts and so forth, but also protecting the employees in terms of who can go back to work and where they should be working, protecting the patients, and of course, not becoming a vector ourselves for spreading the disease through the public. This is eminently scalable because it's smartphone based, but obviously it requires a lot of top-down executive mandate for this to happen. If this were to go live, we anticipate being able to roll our first subject within 24 hours of institutional approval. We've already set up the study, and this is an example of how it's modifiable through an online portal. The general analysis strategy for this is what we've discussed before. Stage 1, data processing from raw to summary, and then stage 2 would be data modeling. And this is an example of one of the reports that can be produced on a daily basis. And this right here is GPS data for one individual. And this individual lives in downtown Chicago. So this here is the lake over here, and this is the Gold Coast. And this, you can see the hot spots of where this person has traveled, incredibly detailed. This is a team, this is JP, Anella, and myself, and we've been working together for about 6 years. And that's all I have.
Very good. Thank you, Dr. Smith. That was a fantastic presentation, both laying the groundwork for what you've been working on historically, as well as how you're transitioning to apply this in the current era. As I typed in the chat, but all of you who are watching now live can also enter your questions in the chat, or you can click the raise your hand function. I can unmute you to ask a question. One question I have to get us started. You mentioned the Google platform. One thing is observation and collecting that data, but you also mentioned the ability to interact and contact an individual and say, like, self-isolate. So are they currently doing that with the Google platform?
No. So right now the Google platform is really an API that's developed for public health specialists, so that if they want to engage that tech for their contact tracing program, they can. But Apple and Google are not taking responsibility for contact tracing themselves.
Okay. And what about the be.we and the current study you're setting up and waiting to get approved? Would that have a component that also engages with the user, or is it more just observation?
That's my point with regards to having something like this based at the point of care, because up until now, at least, the vast majority of testing occurs at academic hospitals or at hospitals. So we are already housing the data of known positives. So for contact tracing, that is the essential element. You have to know who has tested positive, and then you develop a contact tracing network around that known positivity. So in my mind, it makes a lot of sense to base contact tracing from hospitals.
When do you think this would get to go live?
Well, it's an interesting question that, like all things in academic settings, a study like this historically would require 2 years for approval and movement through all committees. Clearly, that window will be closed if this kind of a study takes that long for approval. So we are currently working with the hospital administration for fast-tracking IRB approval. And then at this stage, the next barrier is trying to determine whether or not this would be a mandate for all employees or whether it would be a voluntary opt-in. If it is a voluntary opt-in, then the utility of this program, in my mind, would not approach the type of utility we would need for a public health initiative. It would be an interesting research project, but it would not be useful, in my mind, to actually contact trace without some sort of a mandate.
Mm-hmm. And you've talked previously about the difference between active and passive data. And currently, the hospitals, at least here, are using the active engagement with having all healthcare workers answer these symptom surveys before they start their shift. What do you feel like this is really the passive data adds in this case?
What the passive data adds, at least in the context of this particular study, is the capacity to track movement and create digital social distancing metrics. Because right now, what governors are doing, what the federal government is doing, is asking people to social distance and then hoping that they do. This, through mobility and activity, will give us a much better sense at the population level of where people are social distancing and where they are not. And that, I think, would help us forecast, because it would give us a 2-week lead time, because we know that there's a 2-week lag between when you come into contact with someone and when you become theoretically symptomatic. So we would be able to, I think, be much more nimble and dynamic in predicting where the next micro peak would be based upon social distancing data. And I think that would be very helpful.
Yeah, and there's many of you have probably read the Lipstitch article where depending on seasonality and ongoing studies of the virus, this may not only be the single peak, but these measures maybe need to be in place until 2022. So
yeah, absolutely. I mean, until we have an effective vaccine, the world is not going back to what it was in January.
Yeah.
So if you look at the latest predictions from the IHME, which is the group in Seattle, which is funded by the Gates Foundation, headed by Christopher Murray, formerly of HSPH, of the Global Burden of Disease fame. Okay, so if you look at this group, which is a very, very well-known and highly regarded group, their models have predicted fairly accurately so far number of case fatalities. So as of April 17th, they predicted that the overall fatality rate from C19 in the US would be approximately 62,000 by August 4th. Now, based upon relaxed social distancing across the US, they've amended that model to 134,000 by August 4th. So this is very challenging for Americans to wrap their minds around, but how we behave individually in very small but real ways, summed across a group, will dramatically change case fatality rates over the next year.
And this is obviously the Harvard hospitals, the Harvard institution, the ability to accelerate and apply this high technology is, we're very fortunate about the speed with which we can implement it. Many of our people in the World Federation of Neurosurgeons and the Young Neurosurgeon Forum are watching from other countries across the world in a lot of low resource settings. Do you think that if this dose show promise that this technology could be shared to other institutions or even applied abroad?
I do, because I think it goes back to the scalability of this technology.
Mhm.
So we don't have to buy any new technology for all potential patients. We just simply have to tap into the technology they're already carrying around with them. The challenge will be with data coordination at the public health level in other countries. We clearly have an issue in the US. We have an issue currently with centralization of public health data, as well as implementation of public health initiatives at a federal level. This is something that we struggle with in the US. Other countries, especially in Europe, are much, much better than us at this. So in the developing world, I suspect it will be a challenge. One thing that can be done is if you sort of make this patient or person facing instead of government or hospital facing, you can at least provide an individual with information about whether or not they might have come into contact with someone that was a known positive, and then they can, on their own accord, seek out medical care, attention testing, assuming those are available.
But thank you again for your time. This was an incredible session.
Thanks so much, everyone.